Good evening, dear professor, colleagues. My name is AlShaymaa kassim, radiology lecturer in Ain Shams University Hospitals. I'm here today to discuss some chest complications related to pregnancy, labor, and postpartum. Points to be discussed are physiologic changes during pregnancy, complication during pregnancy, complication during labor, and lastly, postpartum complication. Let's begin with physiologic changes during pregnancy. Pregnancy nearly affects every organ system. Upper airway, nasopharyngeal, oropharyngeal mucosal changes are in form of congestion, being edematous and friable, with high risk of epistaxis. Almost 1/5 of pregnant women develop gestational rhinitis, diagnosed by nasal congestion, as that resolves soon after delivery spontaneously. Blood volume also increases rapidly around 6 weeks of gestation. Blood cell mass increased by hormonal influence. As well as simultaneous increase in plasma volume is encountered, resulting in lower hemoglobin concentration termed physiological anemia of pregnancy. Maternal blood volume and cardiac output also increases by nearly 50% by mid-pregnancy. Cardiac output can increase as much as 80% during vaginal delivery, 50% during cesarean section. Chest X-ray in normal pregnancy. We can encounter chest wall and diaphragmatic changes during pregnancy, including elevation of diaphragm 1.5 to 4 centimeter because of displacement of abdominal organ by gravid uterus, resulting in lower lung volumes. Despite cranial shift of abdominal content, thickness of diaphragm and excursion of diaphragmatic dome remains unchanged. All previously mentioned changes result in pulmonary vascular engorgement, progressive left ventricular dilatation, and mild cardiac hypertrophy. To sum up, chest X-ray changes in a normal pregnancy include prominence of pulmonary vasculature, flattened left heart border, cardiac shadow may appear more horizontal due to increased blood volume and cardiac output, as well as elevation of diaphragms as well noted. There is a chest X-ray in a pregnant female with a lead shield used. Second item to be discussed is complication during pregnancy. Chest complication during pregnancy can include conditions like pneumonia, pulmonary embolism, even amniotic fluid embolism, which may require radiological imaging for diagnosis. Radiological imaging include chest X-ray, CT scan, potentially ventilated perfusion scan, can help in assessing these conditions. However, it's important to be aware of the risk of fetal exposure to ionizing radiation and to choose imaging modalities carefully. Radiological imaging of chest in pregnancy is crucial for diagnosis various pulmonary complications, but radiation exposure concerns must be carefully considered. While chest X-ray are often used as a conventional imaging modality, alternative imaging technique like ultrasound, MRI, often offer reduced or no radiation exposure at all, especially in first trimester when fetal sensitivity to radiation is the highest. Key consideration for radiological imaging in pregnancy: we first prioritize fetal safety. Fetal risk from ionizing radiation is dependent on gestational age. Period of greatest sensitivity is typically between 10 to 17 weeks of gestation. Non-ionizing modalities, whenever possible, we use ultrasound or MRI, which are safe throughout pregnancy. Ionizing modalities, if ionizing radiation is unavoidable, minimize the dose and consider shielding. Chest complications in pregnancy include pneumonia, as we previously listed, pulmonary embolism, amniotic fluid embolism, aspiration pneumonitis, gestational trophoblastic neoplasm, and others. Like exacerbation of asthma, cystic diseases can also affect the chest and may require imaging. Radiological imaging of chest in pregnancy. First, let's discuss pneumonia in pregnancy. Pregnancy is associated with depression in cell-mediated immunity. Patients are more susceptible to community-acquired bacterial or viral pneumonia. Chest X-ray can help assess the severity of bacterial or viral pneumonia. Bacterial pneumonia usually similar in pregnant and in non-pregnant host. Consolidated focal segmental or lobar distribution is usually encountered. Viral pneumonia, we have variety of radiographic appearance, often show a diffuse non-segmental distribution. Pleural disease and adenopathy in viral pneumonia are uncommon. Here are some cases. First, case A, pneumonia in upper lobe. Case B, pleural effusion on the left side. Case C, massive pleural effusion in left side with mediastinal and tracheal shift to the right. And lastly, bilateral pneumonia in case D. Bronchopneumonia with bilateral patchy infiltrate on posterior chest X-ray example. Second one is pulmonary embolism we are discussing as a complication in pregnancy. CT pulmonary angiography or VQ scan are often used to diagnose pulmonary embolism in pregnancy, although there are considerations regarding fetal radiation exposure. CT pulmonary angiography demonstrating here a saddle embolus, while here in VQ scan with an unmatched perfusion defect. There is a perfusion defect with a normal ventilation scan. Radiological imaging of chest complication in pregnancy also include amniotic fluid embolism. This is a rare but serious complication, and radiological imaging may be used to evaluate the extent of pulmonary involvement if necessary. Fetal amniotic embolism is classically characterized, fluid amniotic embolism is classically characterized by a triad of hypoxia, hypotension, and consumptive coagulopathy. However, many times non-classical presentation may also dominate. Amniotic fluid embolism, here an example of a chest X-ray with diffuse infiltration throughout the lungs, and CT chest axial cuts showing homogeneous ground glass opacities. Let's talk about aspiration pneumonitis during pregnancy. Aspiration of gastric fluid and particulate matter that caused chemical pneumonitis and airway obstruction in a pregnant patient causes aspiration pneumonitis. Patient present 2 to 5 hours after aspiration with cyanosis, dyspnea, tachypnea, and tachycardia shock. Radiographic manifestations are variable, although two dominant patterns have been described. One is perihilar infiltrate, and the other is segmental lower lobe consolidation. Bilateral involvement occur in up to 65% of patients. Radiographic findings often worsen over the first several days, but improvement usually occur within a week. Here is a case of aspiration pneumonitis in a 17-year-old female patient who vomited after delivery with GA, general anesthesia. AP chest X-ray show increased opacity for in the right lung base, consistent with aspiration pneumonitis. Lastly, the last chest complication in pregnancy is gestational trophoblastic neoplasm, including hydatidiform mole, invasive mole, and choriocarcinoma. The prevalence of molar pregnancy is approximately 1 in 1,500 to 2,000 pregnancies, with increased risk in women 40 to 50 years old. Molar embolization usually occur early in first trimester or soon after molar evacuation. Chest radiograph may show pulmonary edema with pleural effusion. Process usually is self-limiting, clearing within 72 hours. Choriocarcinoma is a rapidly invading and widely metastasizing neoplasm originating from trophoblastic cell. It can metastasize to lung, brain, liver, kidneys. Local invasion are common at time of presentation. Here is a choriocarcinoma in an 18-year-old woman with vaginal bleeding, markedly elevated beta-HCG, who had a stillbirth at 8 months gestation. Here is a posterior chest X-ray showing bilateral pulmonary nodules consistent with metastatic disease, and subsequently CNS mets developed. Thirdly, let's have a quick overview of complication during labor. Hamann syndrome, a rare complication during vaginal delivery. It occurs spontaneously and often in association with prolonged Valsalva maneuver. This might be explained why there are some cases of Hamann syndrome among young female giving birth. It's characterized by presence of free air in mediastinum and subcutaneous emphysema with no other underlying cause, such as trauma, infection, administration of any sort of mask support with hyperpressure. The common presentation is sub-Q crepitation in neck, parasternal region, right high axillary fossa, clavicle, over the chest. This can resolve spontaneously after a few days of with observation and conservative management. Here is a 24-year-old primiparous woman with a normal pregnancy, presented to the maternity ward in spontaneous labor, 40 weeks plus 1 day gestation. Chest X-ray showing gas accumulation here in subcutaneous with pneumomediastinum. In frontal and lateral chest projections, with continuous diaphragm sign here in frontal X-ray and lateral sign here in front of superiorly and anterior to the heart, shadow. With also lucencies noted along the upper mediastinum to the neck through the upper thoracic aperture. CT showing air within the mediastinum, air surrounding the pericardium, neck level, air within the subcutaneous tissue around the great vessels, carotid space, and in retropharyngeal space. Small amount of pleural effusion are seen bilaterally. The upper abdomen was included in low-dose scan without any signs of air below the diaphragm. Apart from the clinical picture, CT scan is the gold standard in diagnosing pneumomediastinum. Lastly, we are now overviewing postpartum complication, which include pneumonia, pulmonary embolism, pulmonary edema, peripartum cardiomyopathy, postpartum hemorrhage, amniotic fluid embolism, postpartum pleural effusion, pneumothorax, and lastly atelectasis. Pulmonary embolism, the risk for venous, first, its incidence globally is 1 to 2 per 1,000 to 3 per 10,000 deliveries, and 1 death in every 10,000 deliveries. Well, the risk factor for venous thromboembolism is significantly increased during pregnancy due to the Virchow triad, hypercoagulability, venous stasis, and superimposed endothelial damage, all items of Virchow's triad being compromised in pregnancy. Diagnosis is through CT pulmonary angiography. It's common presentation in with the normal physiologic changes as the pulmonary embolism. Both patients have leg swelling, pain, dyspnea, tachypnea, tachycardia, and palpitation, so the only exclusion by CT pulmonary angiography. This is the official American Thoracic Society of Thoracic Radiology in 2011. If suspected pulmonary embolism in pregnancy and there is leg symptoms, we do compression ultrasound. If positive, we treat for pulmonary embolism. This is a bit modified in 2019 ESC guidelines with ESR collaboration, ERS collaboration. Suspected pulmonary embolism in terms of high probability, intermediate probability, and low probability or no probability at all. If suspected pulmonary embolism, we anticoagulate with low molecular with heparin and do chest X-ray, compression, or proximal duplex ultrasound if any is positive, if any of which is positive. DVT is suspected. We do CT pulmonary angiography to confirm and continue with low molecular weight heparin in therapeutic dose. The use of conventional D-dimer threshold in pregnant women has some limitation as D-dimer level increased during pregnancy due to continued coagulation and fibrinolysis during normal placental development and consequently increases the number of false positive results. Negative D-dimer with high risk still test to rule out pulmonary embolism. CT pulmonary angiography can detect very small subsegmental pulmonary emboli, which can be sub-millimeter. Negative CT pulmonary angiography, high negative predictive value, reliably exclude pulmonary embolism even in high-risk group. Here is a pulmonary edema case with the plain radiograph and CT finding including upper lobar pulmonary venous divergence, tag Ansler sign, increased cardiothoracic ratio, cardiac silhouette size. If underlying is cardiogenic edema, radiologists can identify cardiogenic and non-cardiogenic pulmonary edema, which can occur in postpartum period. And this is the CT imaging with bilateral pleural effusion, bilateral more central consolidative patch. Peripartium cardiomyopathy is shown here in this chest X-ray as enlarged heart cardiomegaly with dilated left ventricle, potential signs of mitral or tricuspid regurgitation. Cardiogenic pulmonary edema occur in severe cases. By definition, peripartum cardiomyopathy occur in last months of pregnancy or within the first 6 months postpartum and has no specific cause. Postpartum pleural effusion, as here in the chest X-ray, chest radiograph are the most commonly used. It can provide more detail on the nature, extent of the effusion, including its relationship to the lung and other structure. Chest radiographs are the most commonly used. However, it should be noted that on a routine erect chest X-ray, as much as 250 to 600 milliliter of fluid is required before it becomes evident. Lateral decubitus projection is often sensitive, able to identify even small amount of fluid. And here is an example of postpartum pleural effusion in CT, axial cut. Lastly, pneumothorax, a chest X-ray showing left-sided pneumothorax and recurrence of left pneumothorax 3 weeks after the patient's initial presentation is also encountered. Chest radiographs are essential for diagnosis of pneumothorax, which can occur with labor and delivery and may be accompanied by pneumomediastinum. The risk of recurrence of pneumothorax in pregnancy is high, with the majority occurring during the same pregnancy and during parturition. Thank you.
Thanks a lot, Dr. AlShaymaa, for your brilliant overview about the chest complications in obstetrics. Our next